Hello, everybody, and welcome to our Moving Occupational Therapist Community of Practice for February 2026. Today we have a speaker, Emma Brownrigg, who's going to join us from Poverty Proofing Health from Children North East. We're actually going to take a slightly different tack today. So we will be thinking about physical activity and meaningful movement as part of what we do as occupational therapists. But today we're going to focus more so on how we can reduce health inequalities as part of our practice and how the wider determinants of health impact people's ability to participate in meaningful activities. So I'm really excited to introduce Emma. Emma's from Poverty Proofing Health Team as part of Children North East. She's going to give us a really powerful presentation today on poverty and how it affects people's ability to participate in their meaningful occupations. So I'll hand over to you, Emma. Thank you for joining us.
Oh, you're welcome. Thanks. Hi, everybody. It's really nice to be here. We've done very little work with occupational therapists, but have kept in touch with Lisa along various times, and it's obviously something that's all close to your heart, but also something that you will see probably in your daily practice, those people affected by poverty. So it's a really good forum to present what we do at Children North East, to have a think about the wider determinants of health, and also give you a chance to ask any questions, and I can signpost you to some free training we've got currently with the Nenkai CB. So it's really nice to be here. Right, I'm going to share my screen. We've just had the biggest faff on ever with screen sharing, both in this meeting and my digital inclusion meeting beforehand. So which wasn't me, but it was almost ironically hilarious. So I'm going to see how we get on, and
we'll keep our fingers crossed.
It's all going to work.
We're
going to be there. So we've just got to keep things crossed. Hopefully you can see.
So good. Yep.
Are we there? Brilliant. My goodness, the power of practice. So yeah, I'm Emma Brownrigg. I work for Children North East, which is the longest running regional charity. It's been running since 1891. There's kind of three arms to our charity. So there's the poverty proofing team, which is split into arts and culture, health and schools. There's a therapeutic team within our charity, and there's also a communities team. And we're based in Newcastle, but it's a bit of a misnomer, certainly for poverty proofing, because we don't just work in the North East, and we don't just work with children. So sometimes it can be a little bit confusing for people when they're looking to look into poverty proofing, that they think we only work in the North East. So if you're sat down currently in Wales or in London, please feel free to don't think this is something only for the North East, because it's not. So poverty proofing and Children North East, poverty proofing started with a project that was run by Newcastle University, and they wanted to see what it was like for children living in the North East, particularly those in the more deprived areas. So they commissioned Children North East to do some work, and we gave out hundreds of digital cameras and received thousands of disposable cameras, and received thousands of photographs back. And we found out from there that the worst place to be poor is school. That's where things were the most othering. That's where the contrast between the people who had and hadn't was felt the keenest. And the systems and the structures around school weren't designed in order to have equitable access. And that's really where we come from as a poverty proofing team. So from there, the schools team started poverty proofing work within schools and looking at what those structural inequalities were. And from there, the health team developed and the culture team developed. And that's what we kind of do. So those are our principles. So we work with services to uncover the policies and practice that are making access inequitable. They are unintentional structural inequalities. Nobody sets out to make things harder for people, but you will know, and we know, that those barriers do exist for those people who are living in poverty. So the vast majority of our work is linked to voice. So within these 3 pillars, we've got voice, place, and structural inequalities. That's what drives our work. So when we go into a service, the vast majority of our work alongside training and staff consultation will be the consultation of patients. And we talk to them about the enablers and barriers to accessing those services. We consult with up to hundreds of people per service. We don't talk about poverty. So we don't necessarily, we certainly don't ask them about their finances. I'm really glad nobody ever asks about mine. But we ask about whether they are able to access their appointments, how they got there today, what the difficulties were with things like that. And we look at kind of what's working well and what's not working well. And once we've gathered all of that voice, we group them into common themes. So you can imagine travel is huge, and parking, patient empowerment, so how they feel about advocating for themselves, appointment access and whether there's any flexibility around that, or whether or not it's actually stopping them from attending appointments because of things like childcare and things like that. And communication is a huge one. So how are those letter systems working, the reliance on digital communication, and then we collaborate all of those things into 6 common themes. And we work with services, we feed that back, what we've found, and then we develop action plans with them and give them recommendations and a huge report about the enablers and barriers that we found. We never make assumptions about who's in poverty, so we talk to everybody. And I've got a really good video later on to kind of show you how dangerous assumptions can be and how easy it is to make them. And we also provide, as well as poverty proofing, we also provide training packages on poverty awareness, stigma and unconscious bias, and talking about poverty. And at the end, I'll put the link in for our Boost Learning Academy, which is run by NENC, and we've got free training on there that you can hop onto. You're supposed to be within the NENC, but you can totally swerve it, and you can get some free training if that's something that you feel you would like to do. So that's what our 6-step poverty proofing methodology looks like. So it takes about 12 months in all to do the work, give services time to put the recommendations in place. And so we do staff training and consultation. We do a lot of scoping of the service. So we work out what it's like from point of referral for the patient up till, right the way through the service, and what kind of policies and kind of organisational structures are in place to allow them to access the service. And then, like I said, the vast majority of our patient consultation takes up the most of the work. Okay, and then we feed back and we report to the service, and then we action plan and we look at how they can make changes. And what services often say to us is, this is great, but we don't have money to make a lot of changes. We don't have, there's not a huge budget to suddenly, put on a new clinic somewhere else in a community setting. But there are really small changes that you can make that don't cost anything. Really small, like easy wins. And then we look at those kind of changes, and we also look at maybe more stretch targets or changes that might need trust level advocacy to change, and a bigger changes. And services are appreciative of that kind of range of things. So like I said before, that's the kind of common themes that it comes into. So maybe just have a little look at the slide and reflect on whether or not you see patients having trouble with barriers around these areas. I can almost guarantee transport will be huge. I know you do a lot of home visits, so maybe that's not as big a deal for some of your patients, but if you're expecting them to come into clinics or into community settings, transport can be a real difficulty. And I think I was chatting yesterday to someone who couldn't actually access, they could access the hospital transport, but their partner couldn't, and they could only go on the hospital transport if their partner came with them, and they couldn't. And I was also sharing with Lisa, we were doing some work with Drug and Alcohol Service in Doncaster, And a guy there who was desperate to stay on the road to recovery had borrowed money from a loan shark in order to get a taxi to attend his appointment because Doncaster had taken away the free bus passes. And so he'd gone to a loan shark and he had to pay back double the day after when he got his universal credit. So that's the kind of, it's not easily solvable. Sorting out public transport in Britain is not something that I would expect any of you to feel like you could do really easily. But, there are things that you can advocate for at a trust level, or just make sure things like the travel reimbursement scheme, which is there to use, is really clearly communicated, and that people know what the deal is with that and how your particular service advertises that. Navigating and negotiating appointments is huge. So often people will be given a set time for appointments with no thought as to whether or not that impacts on their childcare. DNAs are a huge problem in the health service, but if we just changed the language a little bit around did not attend and made it into could not attend, then the onus is then on the service to meet that person at their point of need. Now, I'm not suggesting at any point that this is easy, but if you change that language to make it more, give the emphasis more on could not attend rather than did not attend, then that takes away some of that responsibility for those people who cannot attend to sort through what can be a really, really complicated system for them. Patient empowerment is around how they feel about participating in the healthcare system, whether they can advocate for themselves, what the perception is, and then that inverse care law, which is why health inequalities exists, and that the people with the least resources, who often need the most care, are the least likely to access it. And we look at kind of why that happens in different services. Staff awareness and guidance. So we look at how well services are able to signpost, how able they are to refer on, their knowledge around that. I know signposting is a huge issue in lots of services, and people will say to us quite often, can you just make us a signposting document? It's not that easy because things change all the time and communities are different. So it's about having somebody there who can keep on top of that, and I know that's really difficult. Then we look at communication. So how are appointments communicated to people? How's information communicated? We look at health literacy and digital literacy, and around those kind of that language that's used in letters. So we know that the average region age in this country is 8 to 10 years old, and the average letter that is sent out has a reading age of 17 to 18. So unless you have looked at this as a service, you could be sending out communication that can just not be accessed. And I know lots of people have said to me, I've had to, or doctors have had to say, I've actually had to translate some letters from health services to my families because they can't understand it. And I think there's a real fear maybe among health professionals that if they dumb down the language, so to speak, and make it really clear, it sounds like they don't know what they're talking about, but it then excludes the very people that you want to be able to access that communication. So we look at that with them, and then we look at the cost of health. So we ask them, have you been asked to buy anything? So is there a specialist equipment or food? Have you been asked to do any health related activities, and does that have a cost? So that's kind of what we do. And we've worked across many health settings. So we're just starting with neonatal services. We've done extensive work with maternity and drug and alcohol services. We've worked in deep end. And then our major work is in paediatric diabetes. So we've got contract with the RCPCH, and we're doing a national rollout of workshops with the Paediatric Diabetes Network. We're currently poverty proofing type 2 diabetes prevention programs in Wigan. We've got a delivery partner with Ardash, and we've trained them to poverty proof all 120 of their services, which was no mean feat. And then we've done some work with palliative care, and we're currently doing some training and workshops with BNSSG down in Bristol. So we've worked right the way across settings. You can see there's a huge absence there of occupational therapists or physiotherapists. So if any of you have a massive pot of money or even a small pot of money and you want to buy poverty proofing in, that would be great. But the good thing is, if you're with the NENC ICB, we've currently got our contract with them ends at the end of March, and all things crossed, and just the final box to tick, we will have a continued contract with them between March 26 and 27 to work with foundation trusts to poverty proof 2 services per trust. So if this is something that you think would be really beneficial, you know, start banging the drum. But it would be great to work with some different services. So this is kind of yeah, they will be working in many of these services. So this is some of the things that people say to us. So we always try to look at, like I say, in voice. And I think sometimes the things that people say are the things that can be most impactful. So I've actually been on the other side of poverty proof. And so in my previous role, I was a deputy head in a really large primary school in Blyth. And it was really disadvantaged, and we were poverty proofed. And I thought we really had it nailed. Until I got the report, and I couldn't then unhear what the kids had told the poverty proofing team. So I know you will be hearing these kind of things every day, and sometimes it can feel a bit overwhelming when you're hearing things, but you don't know how to, whether you're just the person hearing it or your team are hearing it, but you don't know what to do. So once you get that in a report, that gives you a little bit of evidence as to why something needs to happen, because it won't be that you're not hearing these things all the time. So in terms of transport, this will be something maybe you hear, it takes me 2 buses to get here. Sometimes some of them are full, or the wheelchair space is taken, so I miss my appointments. And you know that in some services, it's 3 strikes and you're out. Some of the bus stops don't have covers either. So if it's raining, you sat there in the rain, it's horrible. It's not a start to the day that you want. If you've got cars, you've then got to negotiate parking. We talked to one old gentleman who was at his appointment 2 hours early because he was so scared he wasn't going to get a parking space, and he didn't want to be late, and he had a suit and a tie on. I mean, he was the most adorable person, but he was so scared of not getting a parking space. He'd gone 2 hours early, and that was taking all of that time out of his day. And then he was going to have to pay the extra 2 hours parking. So in terms of appointments, I had an appointment today at 12 and had arranged with work to have the hour off. So, and then it got rearranged. And they were livid, and it was literally losing money. And often people are on 0 hours contracts, and the attendance of appointments means they're going to lose money, and potentially then they're not going to get shifts the week after. Sometimes it says that I have issues that are personal. If you're seeing someone new every time, you're less likely to open up. Trust is huge in these communities, and if you're seeing somebody different every time and you're actually having to divulge information, new information and sensitive information every time, if that information is linked to trauma, you're then having to go over it all the time, and that can be really, really hard for people. We often talk to staff about how comfortable they feel about having financial conversations, because it's those key conversations, not very, not a huge conversation. It doesn't have to be very long, but just asking someone, is there any difficulty of getting to your appointment, opens up that whole conversation. But staff often say, I don't really ask about people's financial situations. Sometimes they'll say, unless they come in looking very unkempt. Or that might put people off. Or sometimes they say, I would love to ask, but if they tell me they're worried, that there's a financial issue, I don't know what to then do to help. And that's where that kind of signposting and referring on and not having that really peripheral knowledge of what's going on in the community that can support those people is an issue. Somebody says here, poverty is not a medical issue, therefore I wouldn't address it directly. Well, I think they need to come on our training. We have actually had a consultant say, in some training, we were working in Oliver Fisher down in Medway in Kent, which is a neonatal unit, and he was in quite a big room of different staff there, and he said, well, I can tell you something, there's no poverty around this table. And one of the nurses stood up and sort of banged the table and said, hang on a minute, you know, you literally don't know what you're talking about. And that's what we're seeing more and more. NHS staff, working people who are facing that in-work poverty, as well as the patients that are then, you know, trying to access the service. In terms of communication, I was unable to read the information and embarrassed to ask further. So that stigma that is attached to poverty is huge. I felt the doctor rushed me out of the door. And then hidden costs. Some patients are recovering from eating disorders and have to eat really nutrient-dense food, like lots of meat and real meal replacements to build them back up, and it's very expensive. So you can see, you know, none of this will be new particularly, but I think when you see it in layman's terms, in black and white, and also coming from families and patients who will be very like yours, it's really impactful. And so this is a short video about one, not making assumptions. It does cover food, and we know food insecurity is huge and getting worse. But this is why when we go and do patient consultations, we talk to everybody. So everything crossed. If you can't hear the sound, wave at me, Lisa. So I think there's a little caveat to that video in that there is some quite othering language in there that she uses about, you know, it's not what you see on telly. It's not just somebody spending money on beer and fags. But it does show that sometimes we make assumptions about what poverty looks like. And therefore we think that the only kind of caveats we need or extra enablers we need are for those people who look like they're in poverty. So in terms of physical health and your role, we know that poverty reduces opportunities for movement because financial stress impacts physical and mental health. So poverty increases chronic stress, which activates the limbic system, as you probably know. But the limbic system is responsible for threat detection, emotional regulation, memory, stress responses. And so if you're living in poverty, that means you're living in constant uncertainty and what looks sometimes to the outside world like chaos. So you are uncertain about money, housing, food, safety, stability, and it creates chronic stress, which keeps the limbic system in this heightened state of alert. Chronic stress and poor housing and reduced nutrition and fatigue and pain and long-term conditions all are going to limit the effect on mobility and participation. Environmental factors like overcrowded homes, unsafe neighbourhoods, sometimes a lack of green space can make it really hard to be active in daily life. People in poverty often experience higher rates of illness, disability, reduced healthy life expectancy, limiting engagement in physical activities. That's where you're seeing those health inequalities and those multiple comorbidities. And advice assumes time, money, space, and stability, creating unintentional barriers. So, I'm sure that you're more than aware of the limitations of some of the advice that you can sometimes offer. So if you're advising somebody to access a leisure centre, for example, and they can't get there, they don't have the money to get there, they don't have the stability to be able to kind of put time in every week at the same time, then they're not going to be accessing the people who need to access that the most are the least able to access it. And by understanding the lived experience of poverty, I think as a group, you can adapt your interventions and reduce barriers and support more meaningful and achievable activities in your daily routine. So you're ideally placed to bridge that gap, but it's about really understanding what those barriers are. Stigma is huge in terms of engagement. So stigma, people who experience poverty feel very judged by the health service and activity settings. And, if you've also got poverty and obesity are hugely linked because, like we've said, nutrient-dense food is often much more expensive. So accessing those activity settings or those activities is really difficult, and there's a fear and a stigma there, which lowers confidence and a willingness to participate. There's concerns about clothing, equipment, appearance, not fitting in. All of those things can stop people joining groups. And if you're assuming time and money and transport and space and stability, you're going to be unintentionally excluding those with the least. And past experience of judgment can make people really fearful of engaging again. You're there and you can break the cycle, but understanding what that stigma looks like in your patients is really important. And so when we look at outcomes for any of our poverty proofing work, it's usually the same. So improved health, well-being and education, organisations that have a poverty proofing ethos and a poverty sensitive policies and procedures. It's really having that kind of poverty lens and looking all the time to minimise the excess of costs and maximise engagement and social justice. So I would say my top takeaways for this, something that I want you to really remember. So shift the question. So not why is there a lack of engagement, but what does engaging cost the person? Is it time? Is it money, energy, confidence, childcare? And when you change that language around, you change the responsibility. So instead of, like I say, saying, why are they not engaging? It's what does that engagement cost? Availability isn't the same as accessibility. Lots of services and interventions exist, but are they realistically usable for the people who need it the most? And the other thing is ask about access directly, build it into your routine. Try not to worry about the reactions that you're going to get. Almost universally, patients say to us, I wish somebody had asked. I'm not embarrassed about saying, I did find it difficult. It's one simple question. Is there anything that might make it difficult for you to attend this? And open that conversation. And that creates space for honesty. So build that trust, with your patients, which I know you will do through their care, and you will have very much hands-on relationships with these people. So normalise the barriers so people feel safe to share the same information around access as they do around their health. And there's a cool pair of glasses to end with. Get on that poverty lens, and amplify the voices of the least heard to the decision makers, to improve access. So that has been really fast. I've talked very fast, but hopefully that's been useful for you. So I'm gonna.
That's fantastic. Thank you, Emma. That was brilliant, and I think has probably given all of us a lot to think about in terms of our practice. I think it is one of those light bulb moments where you go, yes, I am seeing this when I'm out in the community, when I'm in a hospital setting, wherever we're working. It's a lot for us to think about in terms of, yes, we are seeing this actually in our practice. I really like your tip around not being afraid to ask, well, what is it? Is there anything that stops you coming for, or that made it difficult to come to this appointment today? Or, why couldn't you access this service maybe? I think that's a really good point, that if we don't ask, we probably aren't going to get any information on it. People aren't necessarily going to feel comfortable to volunteer it. So it is addressing it. Do you have any certain phrases that you tend to use, Emma, or that you would recommend?
I think it depends how much time you've got.
Yeah.
So when we go and speak to patients in services, we have lots of questions around those 6 common themes. But if you're short of time, just asking, how able are you to get here, or is there anything going to stop you attending your appointment or your kind of activity, and then wait for that conversation to, and if it doesn't come naturally, first of all, practice. And also, from my previous life in schools, we always used to use win. So I'm wondering, I'm imagining, I'm noticing, and that can get you a long way for opening conversation. So I'm noticing when I talk to you about going to the activity centre or participating in that activity, you pull a face. I'm wondering where that's coming from. What is it that's making you feel? I'm imagining you feel a bit uncomfortable. I'm wondering what that is. So yeah, that's it. I always use win, and it usually works for most people. Wondering, imagining, noticing. Some people don't like the imagining bit because they're like, you don't know what I'm thinking. But the wondering and the noticing is really good for opening conversations.
Absolutely, yeah. Thank you. That's great tip, and a nice acronym as well. I'm gonna make that.
Love an acronym.
Does anybody have any questions at all? Please feel free to unmute or put your hand up or type them in the chat. We'll be checking on the chat as well. I know there's been some really good resources shared in there as well, so do check out some of those resources. Liz, you've got your hand up. Go for it.
I never was the first one to put my hand up when I was at school, but I'm always the first one now. Confidence with maturity. I was just struck by, you reminded me of what it was like to be a clinician, actually, always putting in do not attend, do not attend, do not attend, do not attend, could not. And I think I always knew as an OT, I think person as a healthcare professional, it was always probably could not attend, or, it was like probably need to attend but can't for so many reasons. And but it just made me sort of think about managing the pressures of managing your caseload, and it became a do not attend became a big way in which I could manage my workload, and it was kind of built into the whole way that the service managed the service as well. It's kind of like we actually needed people in the end not to attend, because if everyone attended, we would not be able to cope. So it just kind of made me kind of go back, and how I actually just got used to that. And even when I tried to sort of challenge it or kind of work with that, it created more problems than I could cope with. So I just thought I'd share that as a reality of working for the NHS at the time. And I think also another thing that you said around it not being a medical issue. So why would I focus on it? And it kind of, I feel like I come from things in a sometimes in a back to front way, because I think my OT mind um does think about things in a broader sense. And when I'm learning more about population health and public health and the kind of wider determinants of health, we know that it's all well connected. It's all connected. And I think our OT brains do think like that. It's often the service design that restricts us to think in that kind of broader lens. And it's kind of knowing where your line is as a healthcare professional, and what your service design allows. Because if your service design does not allow you to think beyond the scope of somebody's condition, then we haven't got time to think about somebody's lives, their financial situation, which is terrible, and which is a terrible reality, isn't it? So I don't know, any other reflections on that one, I'd be pleased to hear.
You're not the first person who said that do not attend gives them time to actually manage their workload. We've spoken to GPs who, I was just on a call with some GPs the other week, and they were like, yeah, it's like a breath of fresh air when somebody doesn't walk in. Unfortunately, it's usually the people who you most need to see that don't attend, and your caseload is taken up with people who could maybe, wait a little bit. But yeah, I get it. I get it. It's really difficult.
That's a really interesting reflection, isn't it? That the people who are able to access the service aren't necessarily the ones who actually need the service. And I think that for the majority of clinical staff, we kind of recognise that sometimes. And it's who else is in our community who isn't being seen, who does need the support. And yeah, I think that's a really good point. Daisy, you've got your hand up.
I just wanted to carry on, Liz, your train of thought, really, that some of the work that I'm doing. So I'm in Derby City, and I'm working with the city's reablement service to kind of pivot it to look out and see that there's lots of other services that could help it. And there's lots of other places in the community that could help its challenges. So to speak to what you're saying, Liz, where people haven't got time, actually, in Derby, there's a whole service called Local Area Coordination who have got, there's no boundaries on their how long they can work with someone, but they're completely not plugged into health. And so there's this massive gap. And so I'm kind of professionally tinkering to say, you guys say you do this, you guys say you do this. Do you know, if you just spoke to each other, maybe you could help people. So I'm just as interested, Emma, in your reflection that what I'm finding in my work, people say, we haven't got the money, we haven't got the time. And I'm going, I don't think it's going to take more time. I don't think it's going to take more money. I think it takes us having a different mindset and owning these challenges that our systems have created and thinking that we can overcome them together. And what's been really lovely and it makes me very happy is that that is starting to work on a really minor scale, and people are realizing that the resources are out there. We don't have to spend more money. We just need to have a different perspective and realize that we can do it together, which I know sounds really twee, but is actually the solution. And I was interested, Emma, in once you've made the action plan with the service or the organization, I guess how much support do they need, and do you offer that, or do you politely leave them to it and come back to them? Because I guess what I'm finding in my work is I'm almost role modeling. Do we dare to dream that things could be different? Could we do it in this way? Shall we give it a go? I'm by your side, but you're the one who's going to be doing it. And then for me to kind of retract and leave them to it. So just was wondering if you've got any reflections on that action bit and how that tends to play out or doesn't.
It varies from service to service. We offer support if they need it. It's a little bit of a balancing act. It's like a psychological dance between leaving them to reflect and having some ownership over it, and actually absorbing the action plan and thinking, right, what are the deal breakers? Are they big things that we need to advocate for, or do less but do it better and make sure we really crack a system? Or do we do the little things that are easy to get kind of done and don't take a lot of money? So, but we do provide ongoing support for that if that's what's needed. Like I said, I'd been on the other side of it, and I got the little things out of the way first, or what I thought were the little things. That then snowballed into something bigger. But like you said, I think it's just about having those early adopters and those really passionate people who will continue to advocate for this and continue to revisit. So sometimes you put something in place and you think you've nailed it, and then, you know, if you go back and just do a little bit of patient voice, they might go, yeah, do you know what? It is better. However, by fixing this, it's like whack-a-mole, isn't it? And I think all of us recognise we're not going to solve poverty. We're not going to solve the very complex system, which is the NHS. But it's full of people who really want to make a difference. So it's finding your champions and finding those voices. And it sounds to me like you've got a really good pivotal role in between, like almost like a foot in both camps. And that's where I guess people like social prescribers and community and VCSE sectors can really support in those kind of roles. But yeah, we do provide ongoing support if people need it.
That's really interesting, and it really reflects my experience of that, where I find the good eggs. That's what I found. I start with the open doors, and no one disagrees either. That's what I found, is that people can be really honest and vulnerable about actually they're not that happy at work because they do need the do not attends to be able to manage the workload, and they're really stressed. And actually people have been really honest with me about feeling like that, because I think they know that that might go on somewhere. So yeah, no, thank you, that's really helpful.
Fab. I think there was a point in the presentation as well, Emma, where you said that occupational therapists are uniquely positioned to be able to support this work and to do that. And I think it's really interesting, isn't it, thinking about our role as OTs and like my experiences in different services that I've worked in. Sometimes because we do have that holistic perspective and we're not just focused on the medical side of things, some of those quotes were, well, I wouldn't even think about that because I'm focused on the medical, perspective. We're often seen as being people who maybe block up systems because, you've got a person who's in a hospital who can't go home because, I don't know, the roof's leaking and asbestos is leaking. Like that was an example from my own practice, that we were blocking that hospital bed because that person couldn't go home. But actually the effects of poverty meant that they couldn't go back to their home because it wasn't safe anymore. So just really interesting examples of, well, the medical people have said it's fine, but actually that's not the reality of somebody's life. And we might be the only ones who kind of pick up on that. So yeah, I just think that's really, really interesting reflection that you've kind of said, actually, as a profession, we're really well placed to do this work.
Yeah, and you do lots of hands-on stuff, but you also do lots of talking around their lives and what's going to make it difficult, or like you say, or difficult for them to get home. You visit them in the home. So a lot of those barriers that other clinicians have that exist mean that they're already not there. And you will have really strong relationship. Everybody is relational and will put their trust in the people who they have those strong relationships with them. And so I think it's just really important to realize what a pivotal role you can play. Yeah.
Thank you. Thank you for sharing that and pointing it out to us. I think we feel it, definitely. Does anybody else have other questions? I know, Emma, you've shared some resources in the chat there. Do you want to just chat them through a little bit as well?
Yeah, so the Boost Learning Academy is the platform that NENC use, but on there we've got poverty awareness training, stigma and unconscious bias training, talking about poverty. We've also got toolkits available for all of those common themes that come through the reports, the appointments, the staff awareness, things like that. So there's toolkits available on all of those for you to access. And the training is usually an hour. It's usually like 9 till 10 or lunchtime, and it's with a coordinator and it's quite interactive. So you are supposed to be part of the NENC to jump on it, but you haven't heard it from me. And it's you might it's a really good dipping your toe in it if you wanted to learn a little bit more and have those kind of chats around those chats with other professionals from all sorts of different services around what you see. And so yeah, there's that, and I've put my website on my email address on there as well if anybody else has wanted to get in touch.
Fantastic. No, thank you for sharing those. Oh yeah, so Barbara's just asked about the PowerPoint as well. Are we happy, Emma, are you happy for us to share that as well? For us to be able
Yeah,
to,
yeah, that's fine.
Hopefully. I've also just posted into the chat in case people are thinking of poverty proofing, yes, from an individual level, but also thinking about poverty and kind of the wider effects of deprivation and what that looks like in different communities. So I've just put in a couple of links there for ways that we can think about that wider deprivation and maybe thinking about things from a population level as well. So there's a couple of resources there and the deprivation mapping, indices of multiple deprivation, and the fingertips tool as well. So just a couple of things that you can have a look at and play around with, just gives you a bit more data on, yes, I don't think we necessarily need a map to tell us when we go into different parts of our community which ones feel like they're more deprived than others. I feel like we would know that by going into our own communities, but just having that data to back it up and potentially evidence the fact that we might reach out more so to more communities. Daisy, go for it.
I just wondered if, for everyone really, any thoughts? And I think that we gather so much insight. So I know it's not patient voice necessarily, but actually we do see in building those relationships with people, those reoccurring issues where actually, you've seen 5 people that day and they've all had the same barriers to accessing whatever. And I guess is there any thought on as a sole OT where that information can go and influence? What I'm interested in, the work that the team that I work in is the weight management stop smoking program, and we've got this team of amazing advisors, and they're working in communities day in day out and building these really brilliant relationships over a long period of time with people. Yet they don't see it as part of their role to share that insight onwards. It's more so the kind of how the insight impacts the design of their service, if that makes sense. And I'm interested in, do we see ourselves as being able to advocate and share that insight onwards? And so I'm thinking beyond my line manager, who in my local area is interested in actually the bus service doing this route means this for people accessing, and we are gathering that information. So I know, Emma, obviously that's different from like the poverty proofing methodology, but one, do we see it as our job to share that insight? And two, if we do see it as our job, where would that go?
I think that's a really good point, Daisy. Is we gather, like you say, we do gather a lot of different insights from our work. Like we go out in communities, we're aware of what's going on, and we do advocate as part of our role. Like I think that's a big part of OT. So Emma, when you mentioned in your presentation about, maybe we can't solve transport issues and things like that, actually we do gather those insights. And I know there are really good examples, thinking about Sport for Confidence. There were a group of OTs within Sport for Confidence that advocated for, I think it was around blue badges and us being able to assess for those. So again, opening up that ability for people to access, being able to park in different places. Also thinking about bus passes. I think it was Lindsay who was, Liz, you might be able to correct me on this, who was wanting to be involved in being able to assess for somebody to be able to have a bus pass. And I just think there's so much there around us advocating for people within communities and for that wider community as well. Like you say, Daisy, where does the bus route go? Can it actually, be accessed by the people who need it, or is it just going along a major route and actually the people who need it are over here and can't get on there? Yeah, I think that's a really good point.
I have current beef with the local leisure centre, because it's unaffordable and accessible from a variety of perspectives, and I keep gathering that insight. And so I have through the position that I have, I'm able to build a relationship with the leisure centre to share that. But I guess I'm thinking that if I'm an OT in a service that is a much more boundaried remit, where does that insight go? And is it seen as part of our role? And yeah, I guess that's not just about OTs. All the people who are working with people will be gathering that insight as to why people aren't attending their appointments, but not necessarily think that it's their business to
Yeah.
to advocate
Where does it get
onwards.
fed back
Yeah,
to?
yeah.
Yeah.
And I'm not getting very far with the leisure centre either, because they obviously don't want to, because I'm going, I'm telling them bad news. So that's interesting as well. So yeah, what you do with it. But I am making good routes with the bus company, you'll be pleased to know.
Oh, fantastic. Oh, you'll have to come on and tell us all about that, Daisy. We should have a session on that kind of advocacy piece and how that looks like in communities. Because I think you're right, there are lovely, community assets out there that people just can't access. And that's so sad that, it might be that they're really interested, but actually they just can't get there, or the affordability of it isn't there. So yeah, there's so much there, isn't there, around, well, is it part of a community asset if none of the community are going to it? Yeah. I'm just reading through some of the chats as well. Really, I love that reflection. I feel like being an OT is like a Rubik's Cube at times. Yeah, that's fantastic. Yeah, it is. It is about advocating, yeah, to reduce barriers, definitely. I'm
I
just
think
wondering,
one of the
sorry,
things
go
that we have as part of ours is ask, listen, act, and advocate.
yeah,
And like you say, if you're hearing that stuff all the time, I mean, our work wouldn't exist without those quotes and that patient voice. And we have a vehicle of which to present that to services. And it's so powerful because once you've seen it written down or you've heard it, you can't unhear it.
yeah,
But if you're just hearing it as part of every day and it's just becoming part of your psyche and with no kind of vehicle with which to channel that to evidence what you know needs to happen, that's really frustrating for you, I
yeah.
guess. So maybe
just
as a
becomes
group,
part of,
yeah, start to gather
part
evidence
of
around
people's,
the kind of barriers, and that
yeah.
because it is so powerful in terms of presenting to commissioners or presenting for funding and things like that. Patient stories and case studies are really, really powerful.
That's a really good point. Does it just become part of our reality within a service that, we know that not many people from this part of the community attend, and that's just how it is, or we know that people can't get here on a bus and that's just how it is. How can we take that information that is really useful to services actually and advocate for them to change that service to meet people's needs?
Because if they don't know, how are they
No,
meant to make
yeah,
themselves more accessible? Otherwise, they might, but leisure centre days, you might think, oh God, here she comes again, banging that bloody accessibility drum, but nobody else is saying it. And, unless you've got direct patient stories or you're a group, you're an empowered group, sadly, lone voices don't often have that same impact. So if you're hearing it and if your team's hearing it, gather some of that evidence together and see what happens when you present it, see who'll listen.
Just to say as well, just to add that I can see the real value in that external, you're coming in to support a service or an organisation or a way of working. In the work that I'm doing, lots of staff are kind of just getting on with their day, including OTs. They're kind of getting on with their day. They've got they're not happy at work. They're really kind of professionally dissatisfied with the kind of OT that they're doing. They feel, all of the kind of usual dissatisfaction that we might have. But because I'm an external person who gets it enough that they feel confidence in talking to me, but I'm external enough that they're not gonna, I'm not gonna run off to the manager to say Emma and Lisa said this. Um, that they share much more, and that insight feels like it's much more meaningful, and that it brings it together. Because actually, I go, yeah, you're not the only person who's saying this. Actually, I've heard this here, and here, and no one can disagree with what we're saying. It feels, it's very normal life, obvious stuff, but no one is saying that out loud. So a lot of what, the examples that you shared are really obvious things that are just getting missed through service design, or not listening, all of that sort of stuff. And so all that to say, I can see the value in that kind of external process of having someone to talk to in confidence. And because people aren't loving life in their jobs, that all of these barriers are also impacting them and how they feel about coming to work, and not feeling empowered to be able to address the barriers that people are sharing with them is not a nice place to work either. So it's in everyone's interest to be addressing them, I think.
Yeah, and there's that power imbalance, isn't there? So the kids in my school would never have said some of the things that they said to me because I was the deputy head, and they didn't want to upset me, and they wanted to stay on my side, but felt really able to say, actually, when we get a free school meal and it's wrapped in brown paper, it makes us stand out, when we go on a trip, so I don't go on the trips. And it's things like that you can maybe say to an outside person that doesn't have that same relational power kind of thing going on.
Really. I'm just really aware of time and that we're almost at our hour. Thank you everybody for coming along today and for a really good discussion. Thank you, Emma, for a brilliant presentation that I think has really made us think about, I agree, Liz, big round of applause. That has really made us think about like our practice as OTs and thinking about those wider determinants of health, and how we address those in our practice. So thank you, Emma.
Welcome.
Okay.